Hi, everyone. This lecture is on normal anatomy and physiology of the swallow, or I guess I should say the anatomy and physiology of the normal swallow in adults. And it corresponds to chapter 2 of your textbook. Um, just as a reminder how to use your textbook, I'm going to give you really everything I think you need to know about the anatomy and physiology of the normal swallow in this lecture. However, in order to really understand it deeply, you should use your textbook. My suggestion is to read the textbook quickly, at least to know what's in it, chapter by chapter as we go through it. So this one's chapter 2. So you should scan it or read it real quickly. Don't try to learn it, or especially don't try to memorize it, because what you need to memorize will be in the lecture. And then from that point on, by all means, go back to the textbook on anything and everything that you don't feel real comfortable with. And that would be perfectly normal, that as we go through the lectures, they seem straightforward, but it takes a while to absorb the concepts and to really understand them. And so anything that doesn't feel quite comfortable yet, we'll have time for question and answer, so that will help, and problem solving, that will help, but also your textbook. So I would say scan it or read it very quickly to begin with, even before the lecture would be very helpful, so the lecture is a little more meaningful to you. And then use it from that point on as a reference, where you look things up, like you Google things, well, you look in the textbook, and that's really going to help. And sometimes just reading it in words other than what I have used here will solidify the concepts for you. Okay, so all of that being said, let me share a screen and we'll go to this particular lecture. And here it is. I'm getting to it. I'm going to make it big. There we go. So this is the anatomy and physiology of normal deglutition. Now, I may not have used that word before. Deglutition is the technical term for swallowing. And this particular one's in adults. We'll go through this set of slides in a separate lecture. We'll look at the neurology of the normal swallow. And then in a third set of slides, we'll look at the anatomy and physiology of normal deglutition in infants, up to about the age of 3. And from 3 on, there's not that much difference between adults and children. All right, so first of all, looking at the anatomy. Now, these terms should be familiar to you from 344, from your anatomy and physiology course. If you took it someplace else, it's not 344, but you all had it. But it's been a while, of course, maybe a couple of years. And also there's some particular things, and especially in the pharyngeal region, I find that people don't quite have the, let's say, the 3-dimensionality of the pharynx down pat yet, but I want you to get it so that you'll be able to interpret the imaging techniques that we use in dysphagia, namely the modified barium swallow, but also the fees. Okay, so lips, certainly you're familiar with lips. Don't have to do much on that. Buccal cavity, you're familiar with it. Now, the only one, this is sort of a mid-sagittal image. And the only part of the buccal cavity you can see here is between the lips and the alveolar ridges in the front area. But just as a reminder, that buccal cavity goes all the way around back to about where the pharyngeal arches are, back to about here. So it's like a bit shaped like a big U, the buccal cavity. And why is it relevant to us as we consider dysphagia? Because people, if they don't have good tone in their face, they can get material stuck in their buccal cavity as they try to prepare it to swallow. Alveolar ridges correspond to the buccal cavity. They go all the way around too in a U-shaped pattern. They have the teeth in them. There's upper and lower, and I think you know that. Okay, tongue. From the tongue tip all the way down to the base of the tongue, which is down here by the epiglottis. This region is called the epiglottic valleculae, which I've got down here a little bit later. We'll get to that. But when you consider the tongue and you just look in the mouth, you can see about the anterior 2/3 of the tongue. The posterior third back here is actually part of the anterior wall of the pharynx. So just to keep in mind, there's the anterior 2/3 of the tongue and the posterior 1/3 of the tongue, which you cannot see. But of course it is there, and it's doing things and swallowing, as we'll get into that. In addition to the tongue, we've got the hard palate and the soft palate, both of them involved in swallowing. The mandible, we can't see much of the mandible here, just here, but I think you pretty well know the mandible from your anatomy and physiology course. Here's the hyoid bone. And right here, we see only one part of the hyoid bone at the midline. That would be the body of the hyoid, and it's cut. Just as a reminder, it is a U-shaped bony structure that serves as an anchor for not only the tongue. It does serve as an anchor for the tongue, but it serves as an anchor for some of the strap muscles. And so it's very important as we watch the imaging of the swallow to know the location of that hyoid bone, because essentially it's the part of the laryngeal framework which you want to see elevate during a swallow. It's the part of the laryngeal framework that you can really see. The cartilaginous portions of the laryngeal framework often don't show up very well at all. And particularly in infants, they do not show up because they simply haven't solidified enough to be apparent on an image. All right, so we've got the mandible, we've got the hyoid, now the epiglottis. Here's the epiglottis. I think you're pretty familiar with that. The epiglottic valleculae and the laryngeal vestibule. Now the valleculae, the epiglottic valleculae are here. It's a space between the tip of the epiglottis and the base of the tongue. The laryngeal vestibule is the space within the larynx above the vocal folds. Oh, we'll be talking about that all the time, because one thing in a disordered swallow, you don't want to see material enter the laryngeal vestibule, but often it does. And we'll be looking at describing the laryngeal vestibule a lot. All right, I think I accidentally hit something and made us advance, and I didn't intend to do so. So that is the laryngeal vestibule, this space here. When we look at an X-ray or a video fluoroscopic image of the swallow, we'll see that as sort of a light area that is triangular in shape. Here's the tip of the triangle coming down here, and it's light because it's space. So it looks actually literally lighter on the X-ray. Let's see, now aryepiglottic folds. The aryepiglottic folds, and I'm going to show you another image in a moment, which will make them much clearer. You are familiar with them, but I find this is the area that's most confusing in the sense, I mean, I'm using the word confusing in the sense that it's hard to develop your three-dimensional concept of this region without a little bit of experience. So we'll get that experience in this course. But the aryepiglottic folds run between the tip of the epiglottis and down here where you've got the cuneiform and corniculate and arytenoid cartilages. And then the piriform sinus, also called the lateral channel, is lateral to that. Now here, it's lateral to the folds. It's a space between the aryepiglottic folds and the lateral walls of the pharynx. It's a space, and it's the space through which the material that we swallow goes. So we're going to look at that in another image in a moment. All right, so that completes this slide. Going on to the other one, we're just kind of working our way down into here. False vocal folds, you're pretty familiar. True vocal folds, they're both very involved in swallowing because they have to close in order to keep material from going down into the airway. The thyroid cartilage, we can see a little bit of it here. I think you're pretty familiar with that. And the cricoid cartilage, we can see it here. Here's the posterior portion of the cricoid cartilage and the anterior portion. And that is a part that is very involved in the upper esophageal sphincter. I'm going to mention that term more today. But the sphincter at the base of the pharynx that has to open when you swallow so the material can pass through it, it's actually attached to that cricoid cartilage. So we can say that this is a reference point for the bottom of the pharynx. And below that, we have esophagus. Above that, we have pharynx. All right, so that is the cricoid. These three little cartridges, you know, arytenoid, corniculate and cuneiform, and you can actually see them if, for example, you do a modified barium swallow, you can see them if they have solidified enough. That would be in an older adult. Or if you do a FEES, you can see these little bumps on the base of the aryepiglottic fold. Again, that's the aryepiglottic fold. And these are the little bumps. I'm calling them little bumps. It's not a technical term, but the little bumps that show you where those three cartilages are on each side. Okay, then the pharynx, just this big space here, is divided into nasal pharynx, the part above where you can see, if you just look in a mouth, open your mouth, let me see, you see the posterior pharyngeal wall, not the whole thing though, just a portion of it, in the oral pharynx. So that's, the oral pharynx is the part of the pharynx that you can see if you look in somebody's mouth. The nasal pharynx is above it, and the laryngeal or hypopharynx, also called hypopharynx, is below it. And then the piriform sinuses are out to the side. The pharyngeal esophageal sphinx segment is the sphincter at the base of the pharynx. It's also called the upper esophageal sphincter. It's got a couple other names, but I'll tend to use that term UES, upper esophageal sphincter, the most. And then the pharynx is the continuation of this region we're talking about down. It's the tube that runs down through the chest and to the stomach. Okay, let's take a look at this. Now, this is figure 2 from your textbook. And this is the one I'm showing you primarily to give you a little bit better concept of the piriform sinuses or lateral channels that are out to the side of the aryepiglottic fold. So let me just tick through these, all those things that are labeled on this particular figure. Here's the base of the tongue. That would be part of the posterior third of the tongue. Here is what they have labeled the vallecula. Sorry about skipping. Vallecula is the single term. If you add an E to it, it is pronounced valleculae. That would be 2. And you do have 2 because there's a frenulum in the center of the vallecula, dividing it into 2. And if you do an anterior posterior view, like looking head on of modified barium swallow, and you see somebody who has a little bit of residue left in the vallecula, you can see that there are 2 little pockets, one on the right and one on the left, separated by the frenulum in the middle. This little thing indicates that valleculae is plural, more than one. And in order to be absolutely complete, the structure is, well, it's not a structure, it's a space. The space is called the epiglottic valleculae, or vallecula, depending if you're talking about 1 or 2. As far as I know, and I'm not very certain of this, I'm not aware of another region in the body where you have something called a vallecula, although there might be, but as SLPs, oftentimes we use the term vallecula because we don't even know about any other valleculae. All right, the pharyngeal epiglottic fold is a little fold of tissue that completes the posterior wall of that vallecula. In other words, the reason you can, if you have trouble clearing things through it and you have residue after the swallow in the vallecula, the reason that residue sits there rather than just run down the rest of the throat is that there's this little fold of tissue. So this creates this area that can house about a teaspoon of residue in the area in the valleculae in most adults. So that's the pharyngeal epiglottic fold. And then there's the epiglottis. I think you're pretty familiar with that. The laryngeal vestibule, we talked about it before. And the aryepiglottic fold. It's a fold of tissue that goes between the tip of the epiglottis and down here to where the arytenoid cartilages are located, right here, and comes together. This is the vestibule, the laryngeal vestibule. And these structures, the epiglottis together with the aryepiglottic folds, are capable, not only capable, but do close every time you swallow. What happens is the epiglottis inverts backwards and the larynx rises into it. So this opening, which is called the adductus laryngis, opening into the larynx, closes. And we'll look at the details of that later, but that I want you to be aware of it just as a three-dimensional concept at this point. So there we have the laryngeal vestibule, the area epiglottic folds. Now, this particular photograph of a real structure shows what I wanted to show, mainly why I used this photograph, to give you a good impression of this region, which is not a structure, but a space, called several different things. Some people refer to it as the lateral channels. It's often referred to as the piriform fossa or piriform sinus. You have two of them, so that those would actually be the piriform sinuses. Just add an ES, and you've got one on the right, one on the left. What it's made, what the structures that make up that fossa or channel are the area epiglottic folds and the lateral walls of the pharynx. So here's the area epiglottic fold on your right, and here is the lateral wall of the pharynx. What they have done to create this image for us is to split the pharynx down the middle and pull it out to the side. So this would be a cut edge. There's a cut edge over here, and they have just basically cut right here and pulled it out so we can see now the lateral channels on each side and other things too as well. These are the lateral pharyngeal walls. They have labeled this down here the posterior or posterolateral pharyngeal wall, because this is essentially, here's the cut, and they've just pulled it out to the side. So at this point, you're looking kind of at the back of the pharynx, the wall, the posterior wall of the pharynx, and the lateral wall right in that region. Sorry, I didn't mean to skip there. My mouse is super sensitive. And then finally, we get to the upper esophageal sphincter, or UES. That's not labeled here, but it's right here. It's right here. So above it is pharynx, below it is esophagus. Here they have labeled it cervical esophagus, which means that part of the esophagus, which is in the cervical region or your neck. It's also called what's called several other things. One is the cricopharyngeal sphincter, and oftentimes the cricopharyngeal segment. So anyway, I put this in primarily so you would be able to get a better concept of these lateral channels or piriform sinuses. I tend to use the term piriform sinus a lot, and not because it's any more correct, just because that's what I do. But I'll try to use all the terms so that you have familiarity, because as you read people's reports or you read the literature or the textbook or whatever, you're going to just encounter those different terms. In other words, there's not a single term that everybody agrees, we'll just use that one. All right. Now we've got the anatomy. I don't think we have to introduce any new anatomical concepts at this point, but what I'm going to go into now is the physiology. And we're going to start with the physiology of the swallow by simply dividing it into its three main components: the oral phase, the pharyngeal phase, and the esophageal phase. And the oral phase is divided into two subcomponents: oral preparation and oral transfer. So we'll cover that first. Let's look at the oral preparation. Well, so I'm looking at now, I've labeled this oral phase, but one of the subcomponents, oral preparation. And oral preparation has variable actions and timing depending upon what it is you're swallowing. So dividing it into liquids and solids, and of course there are many different kinds of solids, different kind of liquids too, but liquids basically are going to be processed in a very similar manner, regardless of what particular liquid you might be drinking. And here's how we are going to break oral preparation of liquids down into some subcomponents, I guess you could call them. The first is acceptance. So when we're evaluating people who have possible dysphagia, we start actually by looking at that. You could even say we look at how, for example, somebody would pick up a spoon and bring it to their mouth. That action actually is in the professional domain of somebody else. That would be the occupational therapist. But I think SLPs do pay attention to it because obviously you kind of need to know it. If you got to, let's say you finish your swallowing evaluation and you don't really see any particular problems with swallowing itself, it would be good to know before you write up a set of recommendations as to what they're going to eat, whether they can pick up a spoon or they can pick up a cup. So to that level, I guess you could say we certainly do screen for it. But when I say acceptance, I'm talking about what actually happens to get the material into the mouth. And so basically that would be most commonly, I guess you could say, sipping from the edge of a cup or a glass, or from a straw also. So we look at that. Obviously you need to purse your lips and form a seal against whatever it is you're using to get the liquid into the mouth. The next thing is bolus formation. People tend to use this word bolus as a synonym for what it is you've got in your mouth. That is not the correct use of the term bolus. A bolus is a cohesive mass. So for example, now I'm going to just skip to solids for a moment to illustrate this point. Let us say you take some cut corn, kernels of corn, a spoon of cut corn, and put it into your mouth. It's not a bolus. It's a bunch of corn that can be scattered all over it. And people who are very good at the oral control part of it, it does indeed scatter all over it. Some of it can go down their throat, some of it can go into the buccal cavities, some under the tongue. They haven't formed a bolus. So a bolus isn't just what you put in your mouth. It's only a bolus after it has been contained. So as you are sipping liquid from the edge of a cup, let us say, you have to form a bolus, a single cohesive mass of the liquid. And that involves rapidly transferring it to the palate to form it. Now, the way you form it and contain it is by elevating the edges of the tongue up against the upper alveolar ridge, all the way around, U-shape, and bringing the velum down to the base of the tongue, not the base really, but down to the tongue. Now that forms a seal all the way around 360 degrees. And if you've done that correctly, you've got a bolus and it's contained. So in typical normal behavior, you pretty much have control of the material the whole time. So you sip it in and it goes to that region. The velum is already down. The sides of the tongue are already up. You just have a little anterior opening to get it back into this area we're talking about, sandwiched between the palate and the tongue. Tongue edges up, velum down, and now you finish the sip, tongue tip up, there's your bolus, and it's contained. So that process that I just described is called bolus formation. And bolus containment is the end of that process where you just hold it. Now you can hold it however long you want to. Typically, we don't hold it very long. We probably hold a bolus of liquid less than a second before you're going to go to the next part, which we'll get to, not on this slide, the transfer of it. Okay, so you finish your sipping behavior with liquids with bolus containment. Okay, now let's go to solids. Now, solids is going to be more variable because there are so many different varieties. I gave an example of cut corn, but a spoon of pudding, so, something that needs a lot of chewing. So basically there is acceptance, and that's probably going to be variable too. You can take a bite of an apple. You can bite off something to accept it. You can use fingers or utensils, spoons, forks, chopsticks, whatever it might be, to get the material into the mouth. So we do have acceptance with all those variabilities. And as we evaluate patients who have possible dysphagia, we're looking at all those things. You pretty much can see them, and you pretty much just use ordinary everyday language to describe what it is you're observing. Okay, next step in preparation of solids would be mastication or chewing. And that consists of rotary movements of the mandible, not just up and down, but like this, so that you make use of the grinding surfaces of the molars. So rotary movements of the mandible in coordination with coordinated movements of the tongue to move materials onto the grinding surfaces of the molars until you have chewed enough. So the tongue is detecting materials that need to be moved out there, moving them until you come to a decision, usually not very conscious, although it can be. It's under your control, until you and your tongue decide that the material has been chewed enough and it's ready to swallow. So you continue this basically rotary movements of the mandible in coordination with movements of the tongue to detect and move chunks of solids out to the molars, and then keep that process up until the bolus is ready. I use that word wrong. Until what it is you're chewing is smooth enough that you're going to transfer it. All right. Now, in coordination with that, you must have at all times facial muscle tone. Now that's just it's just the baseline tone that you have here. And the purpose of having tone in the facial muscles is to keep a kind of a pressure there so that the buccal cavities do not fill up with the material that is being ground between the molars. If you don't have tone there, as in the case of strokes, where you see somebody with, for example, a right hemiparesis and a right facial droop, they will tend, as they chew and as they grind, the materials goes both back in toward the center of the mouth and out to the buccal cavities. And so when they finish it up, and oftentimes they don't know this because they don't have sensation there either. They have a loss of tone and a loss of sensation. Their buccal cavities are full of stuff. So that facial tone needs to be there in order to be maximally efficient in this process of chewing and transferring and swallowing. All right, now, and you've got that. It's not anything that it's not exactly a step, it's just a baseline condition that if not present, results in a certain kind of problem, and that is filling of the buccal cavities. All right, and now finally, when you finished the chewing, you form the bolus just like with the liquid and contain it. And at the conclusion of the oral preparation of solids, just as in the cases of liquids, you will have, this should say liquids, by the way, you will have a bolus ready to transfer. And transfer should be our next step. I hope it is. Here we go. Yes, oral transfer. Notice we don't have a difference in oral transfer of liquids versus solids because the process is the same. So this is the second part of the oral phase in which you take that contained bolus and transfer it backwards into the pharynx. And how does that occur? Well, it's not gravity at all. Gravity has nothing to do with it. You could stand on your head and do this. Oral transfer takes place as a result of a wave of front to back elevation of the midline of the tongue. So recall that you've got this contained bolus, the edges of the tongue all the way around are elevated against the top alveolar ridge. The velum is down. And so you've got the contained bolus. Now, to transfer it, the tongue is simply going to elevate up against the hard palate and front to back, and in so doing, push that bolus backwards through the oral pharyngeal port. That is the window between the oral cavity and the pharyngeal cavity. If you just ask somebody to open their mouth, look inside, you'll see the posterior border of the velum, the uvula hanging at the center, and you'll see the pharyngeal arches going down the side. That's the oral, those are the anatomical markers of the oral pharyngeal port. In front of it, oral cavity, behind it, pharynx. So that upward compression of the tongue against the palate, front to back, is going to push that bolus backwards under pressure. It's pressure, not gravity. And it takes about 1 second. So if we go back to oral preparation, the timing of oral preparation is completely variable, and it is under your control largely. For sipping, it's probably less than a second. A sipping and form your bolus, contain it, and transfer it. For solids, it depends upon what it is and how long you choose to chew it. Some people don't chew much. Some people chew a lot more. And so that's completely variable. All right, now we get to the pharyngeal phase. And this slide has mostly to do with when is it? What are the markers for the occurrence of a pharyngeal phase? Well, it starts when the leading edge of the bolus passes through the oral pharyngeal port. So obviously there's overlap between oral transfer and the pharyngeal phase, because you got, at some point, after a fraction of a second, you got half the bolus in the pharynx, in which case the pharyngeal phase has started, and you still got half in the oral cavity, in which case the oral transfer is still taking place. So there's overlap. But that marks the start of the pharyngeal phase, when that leading edge passes through the oral pharyngeal port. And then the end of the pharyngeal phase is marked by when the trailing edge of the bolus, the back part, passes completely through the UES and whatnot. I'm just reminding you of other terms. The duration of the phase is about 1 second. That's why a modified barium swallow is so very helpful, because if we do generally record them, and you can go back and you can even go frame by frame and take that 1 second, which is pretty fast, to evaluate a whole bunch of steps and to see them clearly. All right, so that's just the timing of it. And here are the steps involved in it. And they're somewhat sequential, but also overlapping. And now let's start with that first one, velopharyngeal closure. That has to happen first, because the leading edge of the bolus is almost right there. As soon as you start to transfer it from the oral cavity into the pharynx, if that velopharyngeal valve, V-A-L-V-E, valve, is not closed, the pressure generating the movement backwards that you're doing with your tongue will push it up into the opening, up into the nasal pharynx. So that's going to occur first. Then laryngeal closure very quickly after that is going to start, because by the time the bolus is just about a third of the way into the pharynx, if that larynx is not closed, the material is going to be pushed by pressure again down into the open airway. So their laryngeal closure is essentially the second step. And that occurs in a certain sequence. And I see I have a misspelling here. You have 3 valves involved in closing the larynx. The very bottom one is the true vocal folds. The next one up would be the false vocal folds. And the third one up is the additus laryngeus. And they close in that order. True vocal folds first, false vocal folds second, and additus laryngeus. Remember what makes that up? Epiglottis, area epiglottic folds. Okay, that closes third. The reason for the sequence is that it's protective. We do get things down into our larynx sometimes when we swallow, just through accident. Sometimes you're talking and, while eating or whatever it might be. So it's not uncommon for it to occur in normal people. And this sequence of closures will tend to expel the material that's been aspirated into the laryngeal vestibule before it ever gets down into the trachea or larynx, excuse me, a trachea or lungs, I should say. So it's a protective mechanism to close in that sequence. Now, let's go to additus laryngeus closure and exactly how that occurs. There are 2 aspects to it. One is the elevation of the larynx, and the other is the retroflexion of the epiglottis. The reason there are 2 aspects is if you're just talking about retroflexion of the epiglottis downward, it can't retroflex enough to completely close the larynx. It needs a little help. And the little help it needs is for the larynx to kind of rise up into it. Okay, so here's my epiglottis. Here's my additus. Here's my epiglottis retroflexing. And here's the larynx rising up into it. So you know when that occurs, when you look at somebody who's swallowing, their larynx elevates. How does it elevate? Through contraction of the laryngeal elevators, the strap muscles that are going to pull it up. And you know about those from your anatomy and physiology class. So two things occur. By the way, I didn't put it here. Oh, yes, I did put it here. What is it that pulls your epiglottis down and into the retroflexed position? It is the aryepiglottic muscles. And those are rather not insubstantial. I mean, they're not big muscles, but they're inside the aryepiglottic folds, and they contract to pull the tip of the epiglottis downward as far as it could go. And then simultaneously, you've got the elevation of the larynx to complete the closure. And so this sequence of closure from bottom to top results in expulsion of any materials that may have penetrated into the larynx. I used the word aspirated a moment ago, but penetrated is the correct term. We use that word when we're just talking about materials entering into the larynx, but not into the trachea. And we'll use the word aspirated when we talk about materials going into the trachea. And I'll make that point many times. All right. So now we go into something, the pharyngeal motility that occurs, and it actually is occurring from the very beginning of the pharyngeal phase, because by the time you put things, set things with oral transfer back into the pharynx, you have to start a process of pushing it downward. And again, the downward movement of the bolus through the pharynx takes place as a result of pressure generating mechanisms, not gravity. Proof is you can swallow when you're standing on your head. So we refer to that as pharyngeal motility. Sometimes people refer to it as pharyngeal peristalsis. It's kind of an older term. I think when Logeman first started giving us a lot of research and literature and observations on pharynx back in the 80s, she used the word pharyngeal peristalsis, but she later changed it because a peristalsis is what a tube does to move materials through the tube. The perfect example would be intestines. You know, intestines move the materials through. How do they do it? The ring-like smooth muscles that encircle one after the other all the way through the intestines, they contract in a sequence to push the material through. That's peristalsis. Well, the pharynx is not a ring. It's sort of a ring, but it doesn't have ring-like muscles that go all the way around. The pharyngeal muscles, the pharyngeal constrictor muscles, go about 2/3 of the way around, you could say, like that. They're shaped like that. You know how they're shaped if we look at the pharyngeal constrictors. So the base of the tongue forms the rest of the ring. And so you got different muscles, not a ring of muscles, but different muscles contributing to the movement of the material through the pharynx and generating the pressure to do that. That's not really peristalsis. So that's why she changed later the term to pharyngeal motility, which means pharyngeal movement. So pharyngeal motility is made up of two components. One is the posterior piston-like movement of the tongue base, resulting in a contraction with the posterior pharyngeal wall, and also simultaneously a wave of contraction of the pharyngeal constrictor muscles from top to bottom. So the tongue goes backwards, and just basically it's just basically going to go back. That's why Logeman's term was piston-like. It moves back. And then simultaneously, you've got a top to bottom contraction of the pharyngeal constrictors to push the material down. If you've gotten much into your MBS, that's why I gave a tiny little bit of points extra to do it early, so that by the time you got here, it's what I'm saying right now would kind of make sense, and other similar things. You've studied the stripping wave, which is one of those things you look at in an MBS. You actually see the posterior pharyngeal wall moving forward from top to bottom. And that is signaling the sequential contraction of the constrictor muscles from top to bottom, working with the piston-like posterior movement of the tongue to push that material down through the pharynx, just like squeezing toothpaste out of a tube. That's how it works, but not peristaltically, but rather through the posterior piston-like movement of the tongue and the top to bottom contraction of the constrictors. All right, there's pharyngeal motility. And now the conclusion of the pharyngeal phase is the opening of the UES. UES is normally closed. That meaning the muscles in the UES that make it up, the sphincter itself, are normally contracted. And in order to let material go through, they have to relax. So I'm going to get into that, but I want to first just say, well, why does it work like this? You do have a sphincter at the top of the esophagus, the UES, and you have one at the bottom of the esophagus, the LES, lower esophageal sphincter, also called the cardiac sphincter. And normally, if you're just sitting there or lying there or sleeping or whatever, the muscles are contracted and the sphincters are closed. The purpose of that is to keep materials from the stomach, the gastric contents, as they're called, from coming back up. Why would they come back up? Well, under pressure. Now, let's just say you're sleeping in a horizontal position. Your stomach is full to whatever degree. It could be very full. And as you lie down, just the pressure, lie on your stomach and you can feel it. The pressure will push the material up through the esophagus and back into the pharynx, and you will inhale it then, unless those two sphincters are closed. Some people, you may have relatives, especially if they're older, because it does tend to occur in older people, have what's called gastroesophageal reflux, where there is a tendency for their sphincters not to stay tightly closed enough, especially under certain conditions. If they're overweight, if they have eaten a large meal, and if they have consumed a significant amount of alcohol, those would be the three big things that will cause reflux. But some people may not be overweight and may not have consumed a big meal and may not have consumed any alcohol, and they can still have reflux. So there can be the tendency with age, but the three things that I mentioned are exacerbators of the situation. So that's basically kind of a little discussion on why you need the sphincters and why they're normally closed. Well, in order to swallow anything, you need to open the sphincters. And the first one to open would be the UES. As the bolus gets down to the base of the pharynx, that must open. And the way it opens is there are two components to it. One is the muscle inside that sphincter, which is the cricopharyngeal muscle, must relax. Keep in mind again, under normal relaxed conditions, it's actually contracted. You're relaxed, you're not eating, but the cricopharyngeal muscle is contracting. When you swallow, it's got to relax. So it's sort of the opposite of everything else that's occurring, where you're contracting muscles to move that bolus down. Gets down to the UES, the cricopharyngeal muscle has to relax. So that's one thing, is relaxation of the cricopharyngeal muscle. I'm going to ask you just simply to review your 344 or your anatomy and physiology material, if that or just Google it, if the cricopharyngeal muscle isn't, you're not exactly sure, but it has its point of insertion on the lateral side of the cricoid cartilage. So that's how it gets its name. And its point of origin is the median raphe of the pharynx. So when it's contracted, as it is most of the time, it is keeping that sphincter closed. When it's going to allow passage of the material through it, it's going to relax. Simultaneously, you must have elevation of the larynx. Now, what's happening with the elevation of the larynx to open up that UES is that it's pulling the points of insertion that are on the cricoid of the cricopharyngeal muscle upward and slightly forward. So you've got a relaxation of the muscle, and you've got the whole larynx elevating, pulling the cricoid up with it and stretching that cricopharyngeal. So now it's open. So it's twofold. What's happening is you're dilating the UES opening the UES and doing it through those two mechanisms. All right. Oh, I made a little note here. Recall that this same action, elevation of the larynx, is required for closure of the adductus laryngis. So that again shows that many of the things we're listing here in some kind of a sequence are overlapping, and that's one of them. All right, then the pharyngeal phase ends when the trailing edge of the bolus passes through the UES, that I've already said, and the total time is about 1 second. Now we come to the esophageal phase. When does that start? It starts when the leading edge of the bolus passes through the UES. So again, we've got overlap between the esophageal phase and the pharyngeal phase. Oral phase at this point should be done. So that's not overlapping with this, but you do have overlap. And this phase involves a wave of peristaltic contraction of the esophageal muscles. Those are the muscles that do encircle the tube-like esophagus. So I gave an example of the intestines as having true peristaltic activity. So does the esophagus. And the phase ends when there's dilation of the lower esophageal sphincter and the passage of the trailing edge through that sphincter occurs. That has to occur with relaxation of the muscles inside that sphincter. It's called the cardiac sphincter muscle that's inside of it. Normally it's contracted. When you swallow, it's going to open at the appropriate time. The opening of that LES is simpler. There's just one component. What's the component? Relaxation of the muscle. In other words, UES, we talked about relaxation of the cricopharyngeal muscle and elevation of the laryngeal framework in order to pull the points of insertion of the cricopharyngeal muscle up and slightly forward. Duration of the esophageal phase is variable depending upon mostly what it is you're swallowing. Liquids will go faster, solids go slower. So 8 to 20 seconds, depending upon what it is. And if you have ever swallowed an aspirin, it seems to occur to me on an aspirin more often than other things, I think. But sometimes it feels like it's gotten sideways or something and it goes down and it hurts a lot. And you're painfully aware of the entire 20 seconds it takes for the esophagus to push that pill all the way down through the entire esophagus and finally through the LES. All right. I'm not going to show it here because it's very simple, but do take a look at this 9-minute animation of the normal swallow, which should open when you click that red part on. And also pay attention to the MBS-IMP. This is the same as the link to Module 1. All right. And that completes our, I'm going to stop to share. That completes the recorded chapter on normal swallow in adults. And now, our pattern will be for you to watch the videos in advance of our time to get together. And whether we're meeting live or we're meeting virtually, we will then have 2.5 hours or 2 hours, 45 minutes of question and answer to start with. Generally, we'll have a quiz in there. And the quizzes will be focused. I'm going to use the word exclusively, and I hope you don't ever find a question that's not in the slides, but exclusively from the slides. However, the wording of a question may be different from how I gave it in the lecture. So that's where, using another resource, your textbook, and really understanding it a little deeper is going to help you a lot. So yeah, the quizzes will come from lectures, but the more you understand it, the more natural it is to you, and the more fluent you are with the concepts, the better it's going to work out. And then we'll always have problem solving. So when we get together on this lecture and come together virtually and synchronously, I'll have time for question and answers. We'll have a quiz and we'll have problem solving. And most of the time I will I'll give you some problems in advance to think about it or actually work it out. And then we'll have spontaneous ones too, where I just sort of make it up as we go along, depending upon what's happening in our class. So anyway, that's our first recorded lecture. I hope it wasn't too bad, and I will see you in class.